Buenas tardes a todos. Bienvenidos a nuestra Cátedra de Objetivos de Desarrollo Sostenible para no dejar a nadie atrás. El día de hoy tenemos nuestra sesión principal en donde hablaremos sobre el ODS 3, Salud y Bienestar. Recuerden que tenemos sesiones principales los días martes a las 17 horas, Colombia, y las complementarias los días jueves a la misma hora. El link de asistencia lo estaremos enviando en el transcurso de la sesión. Las personas que deseen obtener el certificado de asistencia a esta cátedra deben asistir al 80% de las sesiones principales. Tengan en cuenta que a lo largo del semestre recibirán unas pruebas calificables, las cuales deben realizar. Si tienen alguna duda frente a esta cátedra, nos pueden escribir al correo catedraods@unbosque.edu.co. Al final de la presentación abriremos un espacio para preguntas y esas las pueden ir escribiendo en el chat de YouTube. El día de hoy nuestra presentadora será Doreen Dunker-Louis, directora del programa Henry Ford Health. Ella dará su presentación en inglés, pero ustedes nos pueden escribir en español y al final podremos hacer esa sesión de preguntas en español. La doctora Dunker-Louis, directora del programa Henry Ford Health, obtuvo su máster en salud pública con énfasis en salud mundial, enfocado en liderazgo, política y gestión en la Universidad de Washington. Lleva más de 20 años trabajando en salud mundial, principalmente en formación y educación sobre el VIH y la tuberculosis. Desde su comienzo en el programa de Global Health Initiative de Henry Ford Health en 2013, ha colaborado con universidades de instituciones de salud y organizaciones comunitarias en Detroit, así como en el extranjero en una variedad de programas de educación, formación e investigación. En su puesto actual, gestiona observaciones, rotaciones, talleres, conferencias y otros programas centrados en el fortalecimiento de la capacidad de los socios internacionales de Global Health Initiative. La señora Dunker-Louis ha participado como docente en varios talleres de investigación y posee un certificado de enseñanza del inglés como segunda lengua. Originaria del Caribe, la señora Dunker-Louis tiene un profundo conocimiento del contexto local y de los retos que plantean los entornos con recursos limitados. La señora Dunker-Louis ha dirigido las actividades del programa de Global Health Initiative en Colombia desde 2018, trabajando con socios en Bogotá, Cali y Quibdó. Bienvenida, doctora Doreen.
Gracias, muchas gracias. Buenas tardes a todos, todas y todos. Es un placer estar aquí con ustedes para compartir algunas perspectivas sobre este ODS muy importante, bienestar. Y yo voy a darle una breve introducción, una breve presentación sobre yo y Henry Ford y la situación, el contexto de este ODS en los Estados Unidos y después podemos hablar.
Claro que sí.
Pantalla, presentación. ¿Sí?
Sí.
Ok. Entonces, yo voy a empezar con la presentación. Las preguntas al final podemos, como dijo la doctora Mayra, podemos hacerlo en español. Si necesita alguna clarificación, mientras tanto, por favor, también los pones en el chat. Okay. Improving maternal and child health in Detroit, Michigan. Como primero voy a darle la introducción, el contexto y algunas estrategias que hacemos aquí en Detroit. Y ahora voy a cambiar a inglés. Unfortunately, my colleague Linda Reyes is not available to join us, so it will be just me. As Dr. Mayra said, I am a program manager and I manage the programs that have to do, all the programs that have involved Colombia. all the projects that Henry Ford International, the Global Health Initiative, is doing in Colombia. I am the ones leading this, and as a result, I get to come and visit you often, and I look forward to coming back soon. So, Henry Ford Health is the organization health system that was established in 1915, more than 100 years ago, by Henry Ford of the cars, the auto pioneer Henry Ford, who was from Detroit. So now he started that Henry Ford Health in 1915 for the employees of the automobile company. And now we are throughout southeastern Michigan, throughout the metro Detroit area, and we have 5 hospitals and more than 30 clinics in this area. And we have a very diverse target audience, meaning that we see people from different socioeconomic status. We see people from different races, ethnicities. We see immigrants. We see people that for who English is not their first language. So very diverse audience. And as a result, our projects, our activities reflect that. So we have more than 33,000 employees, and including more than 1,200 physicians and scientists. And we are a leader in medical education, national, and we also have, as was mentioned before, many international. We do medical internet education internationally as well. We have a formal partnership with a local university, Michigan State University, but we also work with the other universities that are close to us, like Wayne State University in Detroit, University of Michigan, and some smaller universities here as well. And we are known, oops, sorry. We are known for neurosurgery, cardiology, orthopedics, primary care, and cancer, but we do all disciplines at Henry Ford Health. And we have multiple partnerships. I personally think this is very important. We have multiple partnerships with faith based and community organizations around Metro Detroit. So, quickly, the Global Health Initiative, our mission is to advance health equity through sustainable and reciprocal global partnerships. And we basically bring any expertise that we have at Henry Ford Health to share with our global partners, and then which we call capacity strengthening, and then also identify and adapting health innovations from abroad, reciprocal innovation. So solutions that may help, that may be happening in other countries that we could use locally, because we have a lot of local health challenges as well. And the activities that we do are basically a variety of global education and training activities like workshops, conferences, short courses, the exchange programs, the mobility programs. We do collaborative research with our partners globally. We do some consulting, and as I mentioned, the reciprocal innovation, where we look to learn from our partners. For Colombia, just quickly overview in Bogota, we work with El Bosque, with Los Cobos, with Uniandes and the National Cancer Institute. In Cali, we work with Ibanaco and ICESI, Fundación Valle de Lili. And in Quibdó, with the Universidad Tecnológica del Chocó and a community organization, a coalition of different community organizations focused on cardiovascular and mental health. And on the right here are the different types of programs that we do. And oncology is one, HPV vaccination. And as I mentioned, we do a lot of exchange mobility programs. And then one of the other departments that's involved in this, all I'm going to talk about, is our community health department, community health, equity, wellness, diversity, and inclusion. Lots of words. But basically, what we do is focus on being a partner, a trusted partner in health, and provide a variety of services that directly impact the community. So before the community, before patients come to the hospital for care, we do programs in the community, and we also do a community health need assessment every 3 years to really look to see what the most significant health needs are of the communities that we serve. Also, very important is our working with community health workers. My colleague who was going to be here today is a community health worker, and we work with our patients to address challenging circumstances that prevent them from receiving the care they need. So, a lot of the social determinants of health that we will talk about more. So, ODS tres, good health and well-being. Obviously, I think you've talked about this before, but the main goal is to ensure healthy lives and promote well-being for all at all ages. And there are, I believe, 17 targets. No, there are 17 goals, but there are several targets under this. And the one that I chose to talk about is maternal and infant mortality, child mortality, maternal and child health, because that is for the US quite a challenge as well. And the targets are listed here. And I will go into the US context now, just to let you know that the US has the highest maternal death rate of all the countries in the developed world. I don't know if you can see my quotation marks, in high income countries. And in Detroit specifically, our death rate is 3 times the national average. So we have a big problem here in Detroit. Black women are 3 times more likely to die from pregnancy related causes than white women. And that is why we focus on this topic so much in Detroit. The population in Detroit, the city of Detroit, is about 80 to 90% Black. And we have a lot of people with low income and low education and other social determinants that play a role in this issue. Analysis indicates that that for a large number of the pregnancy related deaths are preventable, so they don't need to happen, and we need to address these. In terms of infant mortality, Michigan, so the state, our department, the infant mortality rate here is 38. It's out of 52, so we're in the lower half. And we have for Black babies specifically, they are more than 2 times as likely to die. The same with American Indian, indigenous infants. They are twice as likely to die as white infants. And also, our Hispanic Latino families have higher rates of infant mortality. And then the other part of this, and that we're talking about this more and more, fortunately, is that mental health issues are very important. They impact pregnancy and postpartum, the status of women postpartum. There are many complications during the pregnancy itself, but then 1 in 7 women experiences postpartum depression or anxiety. And the sad part is that half of these women do not get the treatment that they need. So, as I said, I'm focusing specifically here on health inequities in Black women because the inequities in Black women and other minority women is what drives the low rates, the or I should say the high maternal death rates for the U.S. You would think that the U.S. as a very developed country, a high income country with a healthcare system with the best technology, um, very well educated clinicians with many resources, that we would not have these issues. But unfortunately, because there are inequities between different races, between different ethnicities, and often that goes along with differences in social economic status, we have these health inequities. And the the Institute of Medicine itself has concluded that these disparities are a result of racism, and there are effects of racism that put women at high risk of medical conditions. Black women have higher rates of several diseases, and there are complications, there are consequences of these issues that impact Black women's viability, Black women's quality of life in many ways. So, without going in all of these blocks specifically, but some of the things that come up is that Black women are underrepresented in clinical trials. So often we don't have the information that we need to provide the best care and treatment. There are specific health conditions that disproportionately impact Black women that receive very little research funding. So it is really difficult to move forward with some of these disparities. And there is systemic racism and discrimination in the U.S., but it's also implementation of hospital policies that impacts this, and social determinants of health impact all of this. So seeing that Black women, other minority women often receive delayed care or inadequate prenatal care, and they also receive inappropriate or differential care in hospitals. So that is the situation, that is the context. Unfortunately, like I said, even though with all the resources we have here in the US, we have big problems in cities like Detroit, in areas like southeastern Michigan. And this has become a priority both at state level, at our department level, at the city level, so the city of Detroit, and for Henry Ford Health, my organization. So, what I will do now is walk us through several different strategies that we've used. And I think you will have access to these slides later or to the presentation, but you can always reach me directly as well if you have questions about any one of these strategies specifically. And we can talk more about them as well during the question and answer period. But first, I will give some strategies at state level. So, Michigan Department of Health and Human Services is our state department level Department of Health, and one of their programs is Healthy Moms, Healthy Babies. And what that program is extending Medicaid coverage, which is one of the types of insurances that we have here. That a lot of minority women, a lot of women with low socioeconomic status are requiring. And before this, this coverage was only for a certain time while they were pregnant, while they were receiving prenatal care, and while they were receiving, and just for a short time, postpartum. But now it's going to be 12 months, and as a result, they will have full benefits. They will have physical and behavioral health services. They will get all kinds of, they have access to treatment and care that they would not have had otherwise. And again, this is one of the ways that we hope to increase access to healthcare coverage during this important period. So that is one of the options at the Michigan state level. Another option at Michigan state level is the Mother Infant Health and Equity Improvement Plan. And this is really a variety of different interventions that they are doing, all bringing together to work with the not just the mom or the infant, but with the whole with the family structure, and to address gaps and disparities that exist. And they're specifically focusing on social determinants of health and equity, and are building strong partnerships to make sure that all throughout the state, that different health systems, community organizations, women organizations, that are all involved in integrating the different interventions that there are. Now going a level down to the city of Detroit. So those I just gave you two, but there are many more. At the city of Detroit level, one exciting program that we have is Sister Friends Detroit. So, Hermanitas Amigas. And it's a volunteer effort really to help women who are pregnant and their families, to provide support to them until the baby's first birthday, especially for new moms, first time moms, and especially for women who might not have women in their, in their sisters, mothers, family, friends that have gone through this, in order to provide them support and to help them find access to services and resources. This volunteer program has been set up. It's been running for a couple of years now, and it's pretty successful. Another strategy at the Detroit level in the city is the opening of a birth center, the first freestanding birth center in Detroit. And birth centers work differently than health systems, where their care is more personalized, it's family centered, and they continue before, during, and after the pregnancy, and there's more consistency, and they can actually they are able to make it culturally responsive, which can really make a difference for women of color, families of color. So that is another one at the Detroit level. And here's a whole list of other efforts that are happening in Michigan that I picked for you, that you can check out on your own time. But many different, again, this is something that is really important to us here in Michigan. So many different initiatives are underway. Now, going to Henry Ford. So for us, our goal is to achieve equitable maternal and infant health outcomes for Black and Latina women who receive care at Henry Ford Health. And we obviously we strive, we aim for the best health outcomes for all of the women that we see, but these two groups need a little more um, special care to address the disparities that we have seen. And we have a variety of organizational strategies that I'll go into briefly. And then I'll talk about several different programs that we're doing and highlight um, the last one, the WIN network, which is what my colleague who works for that program would do, but I will do my best to represent. So, in terms of organizational strategies, one of the most important things we did was just to identify key positions so that the work could be coordinated well and could be led and would be structured. There would be a system around it, and it would not just be individual activities that are, as often happens in large systems, are being done in silos. Everybody works on their own project, and it's not system wide and it's not coordinated. So we have a director of maternal health equity, and not only is her role to lead the strategy, but at that level, having a director position that can also help us in with other hospital leadership, other health system leadership, to advocate for changes that need to happen. Another very important role was establishing the role of the perinatal safety nurse coordinator. And she does a variety of activities, seeing what we have in place and planning, organizing, working with all the different groups across the system to make sure that we make the right changes to address safety and reliability. We also have a nurse navigator, and I believe now we have more than one, but who are specific to obstetrics and pediatrics. This navigator then works with trained personnel to identify barriers that exist, then works to facilitate, to mitigate those barriers, and ensures that our patients get complete and timely access to the health services. We have a Women's and Children's Health Council. So, all of the programs, all of the interventions, all of the strategies that are proposed are being presented to this council that focuses on women's and children's health, and it consists of people from different departments, clinicians from different departments, but also patients, community representatives, and the community piece comes back in our community engagement, where we have community partners serving on this council, serving on task forces. We participate in community town halls. We have community partners serve on different boards. We serve on different boards in Michigan, just to make sure that the community that we are in constant communication with the community about what the needs are, what solutions are, what concerns are, suggestions, ideas, proposals. And we have within, as most U.S. organizations do these days, we have a specific strategy for diversity, equity, inclusion, and justice, DEIJ. And within that strategy, our health equity pillar within that strategy really focuses on maternal health. And our goal again is to deliver highly reliable, equitable, and respectful maternal and pediatric, especially neonatology, um, care. So, since postpartum hemorrhage is the most common cause of preventable maternal morbidity and mortality, we have an organizational focus on this issue. We have done a gap analysis, and we make sure that risk scores are added into our electronic medical record so that when labor and delivery, when that time comes, they have access to these risk scores, and they can make care decisions based on the risk scores. We also have had the obstetric hemorrhage checklist. We included that in our policy and made sure that every computer workstation in the labor and delivery area has a copy at their workstation, and they're all in each patient room. So we have that ready to go. We also created the batch buddies, where I don't have one. I don't know if you can see mine on camera. This is not the postpartum hemorrhage one, but similar to this, um, we made them for PPH with all the information and provided it to all of the relevant staff so that they have easy access to all the medication information related to PPH and all the stage information as well. And then another thing we did is that we are increasing our simulations in our simulation center. So we have more simulations related to postpartum hemorrhage and have a multidisciplinary team work that so that everybody knows what they need to do when this happens. All right. Um, so that these are a couple of other PPH related strategies where we're working with Premier Health, which is a similar health system in Ohio. And we're basically working with them to do more data analysis. It's actually a national program that I believe 9 or 10 health systems are involved in. We also make sure that at all our sites, at all our hospitals, all members of the labor and delivery team are credentialed in fetal monitoring. So that is also kept up to date. We've also updated our guidelines for blood product release, so we don't have issues with getting blood products in a timely manner during a PPH, and that's been set up as well. All right, I am going to take a breath and go into several of the programs that we have going on. Um, and I have listed a lot, and these are not all, but I just wanted to give you some high level ideas of different activities, different strategies that are being undertaken to address primarily maternal health, and as a direct result of that, child health. So, our unconscious bias training is something that happens not just in women's health, but throughout the system, because it has been shown that unconscious bias among healthcare providers may impact how our patients are being treated, and that could have health disparities as an outcome. It can actually impact health outcomes. So, by reducing or eliminating, ideally, prejudicial attitudes that people may have, or stereotypical beliefs that people may have about a particular social group or members of that group, and it can be really innocent, but just thinking something like, oh, they probably won't come back for that postnatal visit because da 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 da. Da. You're thinking something about a member of a particular group just because of some beliefs that you have about the group, and you may not give them, as a provider, you may not give them the best options just because you have those unconscious thoughts. Not, this is not intentional, but it's unconscious. So we have had system-wide training for all staff in women's health, from the receptionist, customer service, up to the medical assistants, up to the physicians, up to the leadership. And there's more information in that flyer about what that training entails. Another project that we have just started is reducing the impact of severe maternal morbidity, and that is we received an award from the Michigan Health Endowment Fund, one of our local funders that works with the state quite a bit, and a team of specialists in this area are working on a variety of different activities. One being C-sections, which we have way too many C-sections going on. So they're using wireless external fetal monitors to um, to address that and to hopefully decrease the C-section rates. We're providing educational opportunities for doctors, midwives, nurses, and doulas, and on the spinning babies, preparing and caring for birth, doing fetal rotation, and what's going on in the human pelvis. We provide opportunities for nurses with this award to go to educational conferences and also to update our equipment. One super exciting, also fairly new project or strategy is using our mobile integrated health. So we've had mobile health, um, a mobile health system, and for instance, during COVID, we used that quite a bit to go to, not out in the community, but also to people's homes for testing and vaccination. But we're also using this to reduce pregnancy related deaths by going to the homes of new moms who are especially vulnerable. Hypertension, as you may know, is a key driver of maternal mortality, and it often goes undiagnosed. And it can be so easy if new mothers just get their vital signs checked after they return home. So now we're sending paramedics, and they just go and visit new moms at home, take their blood pressure, take the other vital signs, and then they communicate with doctors by text and let the doctors know, what they found, and then the doctor will then order prescribed medication as needed. And women do have to qualify for the program based on certain conditions like gestational hypertension or chronic hypertension if they had preeclampsia. But also, it could also be, lack of transportation or not having had a lot of prenatal care prior to the delivery. Our hospital-based doula program. So they found that doula support definitely has impact on social determinants of health, has impact on perinatal outcomes. So bringing doulas within the hospital, embedded into the hospital as employees of the hospital, that actually has been we think that will lead to improvements in outcomes, so that we can get this care to women who have access issues. The Hope Project is this actually a project that I'm working on myself. The other projects that I'm mentioning are projects that my colleagues are working on. This one I work on myself. It's a primarily because this is a global reciprocal innovation project where we're partnering with a group from Rwanda in Africa, and we are both working on two related issues: healthcare worker burnout among the employees who are working in women's health, and improving the health outcomes for pregnant and postpartum Black women. And we're doing a variety of mixed methods to identify barriers and facilitators to see how hopefulness impacts health and healthcare experiences. And then the idea is to develop pilot and evaluate interventions to address both of those issues. So we're in the process of doing currently, for instance, focus groups with women, both pregnant women and postpartum women, and asking them questions about how hope has played a role in their own pregnancy, or in their care experience, and where they see the role of hope, for their own future, the future of their children, etc. Another project is specifically related to reproductive equity, where and here I specifically want to pull out um, our our focus on the LGBTQ community, where we realize that we typically talk about women, and in my full presentation I talk about women, but this project specifically also focuses on everybody who can birth, basically. So they specify that in their project. So it is reproductive equity, not just across races, but also across gender identities. Um, and doing a variety of social needs screening, making sure that people are referred and get the care navigation they need. And this study is also mixed methods, and they use community health workers in their program and a online family planning tool, planning and education. Another project or another activity that we do is screening for social determinants of health. Now we do that at least for food and for housing. Currently, throughout the system, we also check for safety, if if patients feel safe at home. um, but we're doing this screening now specifically for SDOH, for social determinants of health, and its relationship with maternal health outcomes. And then we collaborate with social services, with case management, and community health workers, again, to connect women, to connect patients to the right services. Midwifery is something that we are using, and from discussions that I've had in the focus groups with women, they really appreciate the our certified nurse midwives. We have several that are, they're educated, and they just have more of the ability, of the bandwidth, the time, um, to provide supportive care and to be more involved with the patient, to have they have more time with the patient to make decisions, and they can independently provide care during pregnancy, childbirth, and postpartum. Because of their level, they are able to do pretty much and almost everything a physician can. So they are very well received by the women. Um, and so these certified nurse midwives provide group prenatal care, which I'm going to come back to in the case study, which I believe is right now. Yes. So I will now highlight one of our programs, and go in a little more detail this one. And after that, we can chat. I'm sure that you have questions. But the WIN network is the Women Inspired Neighborhood Network. And this program was specifically set up to reduce the disparities in infant mortality. So, as I mentioned, our Black babies dying at much higher rates. And what the program tries to do is to really empower the families so that they can thrive and reduce costs for the system, which is always um, a welcome circumstance for a health system. So the program really it's really a community driven approach, and it brings enhanced group prenatal care, doing a combination of the community health workers and the certified nurse midwives. So the community health workers really have the chance to work with the patients, the women, to address SDOH, the social determinant needs, both within the clinic setting, but also during home based visits. And they have the ability to do that during that first year past pregnancy. So there is some continuity with that. Now, in case you're not familiar, community health workers are basically community members, residents who have a close understanding of the population that they're serving, right? So they're people who come from the same community, the same audience, the patients that were working in the group of patients that we see, and they have they share their experience, whether that is because they belong to the same group, whether they belong to the same geography, they're from the same neighborhood. It might be racial or ethnic, or it might be gender or sexual orientation, but they share that experience, and then they're really have a passion about connecting people. um, you can start the CHW position with us with a high school diploma or the equivalent of a high school diploma. And then you're being trained specifically to be a community health worker. And there is actually a curriculum at state level, at Michigan state level. And then the community health workers, they work in the different programs and learn on the programs as well. They are culturally competent. The most important thing is that well, maybe not the most important thing, but one of the important features of a community health worker is that they have the trust of the community. And that has been widely documented. The success of using community health workers as health brokers, if you will, as mediators between health systems, between the physicians, or sometimes nurses, or like people where the community sometimes might not feel that they understand them, or that they speak the same language, or that they have time for them. CHWs are able to spend more time with the patients, and they can be that liaison, they can be that intermediary between providers and the community. And so we have CHWs into our multidisciplinary health teams. It does also, which again, it's very important to health systems as well. It has led to reductions in patient costs. But what we really see is that when CHWs are involved, that patients are keeping their appointments more often, they're more compliant with their prescriptions, risk is reduced, there's blood pressure control, and just in general, they are um, better health outcomes when CHWs are in the picture. So for the WIN network, our first cohort was 323 Black African American pregnant women between those ages, 18 to 34, and they were paired with a community health worker. And we specifically worked with three neighborhoods, three barrios, if you will, that were high need, where we had a lot of issues, and the community health workers worked with these moms and helped them with housing, with employment, with transportation, with navigating the care, the health system, getting to health care, including getting insurance and accessing insurance that was available to them, food, nutrition, but also helping them with goal setting and planning, family planning, um, planning, life planning. And when compared, and this has been studied quite a bit. We've published on this as well. Participants were less likely to need a stay in the neonatal emergency intensive care units. We had fewer preterm births, and we had fewer low birth weight births. And I have some numbers for you in a second. Now, our second cohort is the enhanced group prenatal care. So, in the first one, it was community health workers working one on one with women. And in this second cohort, we're actually um, doing this at Women's Health Services, where we do an enhanced model of the prenatal care, group prenatal care, where our groups are facilitated by both a certified nurse midwife and a community health worker. The groups are 2 hours long, and the first hour is just generally speakers. That's one-on-one belly time with the nurse midwife, and then the second hour is circle time, where everybody gets to share. And then we have a variety of speakers that are involved from different community health groups. We have outside speakers come in, issues like domestic violence, nutrition, but also the birth plan and so much more. The target population is women who are Black women who are eligible for that insurance that I mentioned, the Medicaid. They have to be over 18, between 8 and 28 weeks. They have to be in the Detroit area, and they receive care at one of our main medical centers here in the city of Detroit. And again, I mentioned the important role of CHWs. In this particular project, they serve as co-facilitators, and they work hand in hand, integrated with the clinical team. They are trained as doulas, and they provide all the added support of home visits and coaching and advocacy on behalf of the women. And they're involved with the women throughout prenatal care, delivery, and through that first birthday. And they do what we call the warm handoff, where any resource that they set up, that they organize that for women, they don't just give them a phone number and say, here's the number for housing, call them and figure it out. They actually work with the women to make sure that that connection is made. They follow up to make sure that the connection is made. If they need to go with women person in person to an office, they do that. So they're there really, to guide them through the processes. And some of the team leader is who was going to be here today with us. She is administrative, and she coordinates some of these activities. And then just to get back on why group prenatal care is so important for Black maternal health specifically, it just gives one of the important thing is that it makes sure that our patients are well educated. They know what to expect during the pregnancy, during all the labor processes, newborn care, postpartum care. They know of whatever it is that they need to know, and they we teach them, the CHWs and the nurse midwives work with our patients to teach them how to advocate for themselves so that they can ask questions when they need to, that they can speak up when they feel they're not being heard, when they feel that maybe there is some bias going on, maybe they're not being listened to, maybe when they're asking something, sometimes things that we hear, they're asking, they don't want to do a C-section and they're not being explained why why it's necessary, or they're in immense pain, and they're not getting pain medication, or they're not being comforted. So the group prenatal care is very important to give our moms and the babies the support, and in that way provide support to the community so that we get healthy moms and healthy babies. And we have here some results. Since April 2016, we've done about 52 groups, 349 babies have been born. We like to point out that we have very well attendance of the fathers that have come to at least one session. Often it is thought that fathers, especially Black fathers, are not engaged in the care, and that is, we see in our group that that is not the case. We currently have about 65 women enrolled, and here we have some data about average birth weight and gestational age and um, low birth weight, and but the other important thing to point out is that 97% of our mothers initiated breastfeeding upon birth of the baby, so which we encourage. So here are some results, and I don't have them, very recently. We're still pulling together data from more recent years. But just to give you an idea, how our women in the WIN network stack up, how they compare to the city of Detroit and to Michigan, and you could see, that there are, like more than half in reduction of preterm births. Look at the difference in low birth weights, how many more vaginal births we had, and definitely in terms of breastfeeding, how many more moms initiated breastfeeding. It'll be interesting to see our more recent data. We did not have group prenatal care during most of COVID. We just started back up in the fall of 2022. So, we're getting close to collecting another year of data, and we can kind of, see where things are now. Here are just some thoughts, some perspectives of the moms. Many moms just described the social support as the most helpful aspect. When that they were less scared when they became a mother, because now they had the necessary tools and they had the resources to not only help themselves but other mothers. And they really liked having someone to check in on them and making sure that they were doing all right. Especially this woman is talking about, postpartum depression, where one of the community health workers would call everyone and make sure, that where she was with her feelings in postpartum depression, and just the personality of these ladies. And I know them well. They're, if I were pregnant, I would want them to be with me all the time. And again, as I mentioned, this has been documented. Higher prenatal care utilization. You get the support partners, the engagement with the partners. They are more involved this way. getting education on all of those topics that we talked about. Safe sleep is another one that's so important to to teach the women and their partners about. Looking at all the social determinants again, making sure that women get the resources that they need and walk them through it, not just hand them a number, but walk them through it and make sure that it all, that they've gotten what they need. And they prepare the women, the moms, for birth by taking them on a tour through the labor and delivery. So it's not the first time, when they have to deliver, that's the first time they see it and that they don't know how, it's going to go. They do that beforehand. They create that birth plan, and the CHWs are trained as doulas. And then also, just providing social support, really helping with the stress during the pregnancy. So the impact of CHWs on birth outcomes is really multifaceted, and we will continue using it. There's more information on the WIN Network site, and here's one article that shows the results of community health workers in improving equity. So you could pull that one up if you're interested and get some more information. I want to acknowledge like I said, I worked on the one project, Hope, but many of these other projects that Henry Ford does are being coordinated, spearheaded by different people, and I've listed a few here. And I'll skip this for a second. We'll come back to this. Here in this presentation is also my information and other information about Henry Ford. And this is the beautiful city of Detroit. And I hope you come and visit me once. And that is it for the presentation.
Muchas gracias, Doreen, por esta maravillosa presentación en donde pudimos ver esa experiencia de Henry Ford Health con la mortalidad de las madres y de los bebés. Hay algunas preguntas en general sobre tu experiencia y sobre este programa. Entonces, la primera la hace Miguel Andrés Jiménez y pues la hizo en inglés. Interesante sí.
Sí, esta pregunta es muy interesante. Yo personalmente no tengo ninguna información sobre este tema. No es algo que oigo mucho en Detroit. Cuando es big news, noticias muy largas cuando acontece, cuando esto pasa. En el año pasado, hace 2 años o 3 años que he oído de esto en la ciudad de Detroit, pero en otras partes de Estados Unidos no sé. Es muy interesante.
Sí, para los demás que nos están escuchando, estábamos hablando sobre los datos de mortalidad infantil debido al abandono de los bebés. Entonces dice Doreen que pues esto realmente normalmente no sucede, no hay tanta información. Entonces seguimos con la siguiente pregunta de Luis Felipe González, que nos dice: ¿cómo podemos cambiar la definición actual de salud como negocio y volverla a concebir como servicio? Creo que tiene un poco que ver con el modelo que nos estabas contando precisamente.
Sí, y especialmente en un país como los Estados Unidos, el sistema de salud es tan complicado y tan dependiente de cuánto se puede negociar, cuándo se puede lograr por una visita o por los procedures, los operaciones y estas yo creo por mi parte y por la parte de la salud, de la iniciativa de salud global y el Departamento de Salud Comunitario, lo que podemos hacer es hacer estos proyectos, de salud comunitaria, salud pública, para la
para
sistema,
poder,
sí, para hacer algo. El sistema de salud siempre va a cobrar dinero, la plata, es importante para estos. Y también, como dije en algo, si podemos reducir los gastos de los servicios, también esto es de interés para el sistema, pero sí es un dilema, un reto. Sí.
sí, y muy interesante. Más adelante vamos a hacerte más preguntas sobre los programas. Pero por ahora tenemos otra pregunta de Aura Hasbón Olaya, que también se animaron algunos a hacernos preguntas en inglés. Muchas gracias por la información. Como sabes, en Colombia ha habido una discusión sobre la calidad de nuestro sistema de salud. De acuerdo a tu experiencia, ¿cuál es tu opinión acerca de este sistema?
Yo todavía estoy aprendiendo lo que todo significa estos cambios que están proponiendo. um, no puedo decir mucho. Lo que espero, lo que es que involucran ojalá que involucran las voces de la comunidad en este proceso. Y no sé si esto está pasando, pero como dije, nosotros en Henry Ford y otros sistemas de salud hacemos el Community Health Needs Assessment. No sé.
Que es como una evaluación de las necesidades de la población.
Sí. Y no solamente porque queremos hacerlo, pero necesitamos hacerlo para mantener nuestro estatus de sistema non-profit.
Sin ánimo de lucro.
Sí. Y entonces, pero esto nos da las ideas y las sugestiones de la comunidad para nuestra estrategia. Y esto es mi opinión, la única opinión que tengo en este momento es ojalá que esto está pasando en Colombia también, que están involucrando la voz de la población.
Ok,
No
claro
sé,
que sí.
no sé si.
Bueno, continuando con nuestras preguntas, Soledad del Rosario de la Cruz nos pregunta, ¿qué efecto tiene el nivel educativo en la salud y la relación entre madre e hijo?
Lo que puedo decir sobre el nivel nivel de la educación es que en los Estados Unidos las inequidades, las disparidades no dependen del nivel de educación. Sí hay un impacto, sí, pero los outcomes, the health outcomes de mujeres que tienen educación de posgrado que son afrodescendientes, negras, tienen más, ellas tienen más retos, más problemas que personas que mujeres con menos educación, con menos dinero, menos estatus social, socioeconómico. Entonces, pero sea, hay estudios, hay investigaciones en la, cómo impacto, cómo influye el nivel. Yo no tengo toda la información, pero sí sé que tenemos el problema con que la educación no importa mucho en en las disparidades.
Perfecto, sí. Es un problema que todavía hay que seguir revisando y pues una de los puntos de la presentación es como todos los otros elementos sociales aportan a la mejora de la salud, que es una sola salud. Entonces, Miguel Andrés Jiménez Pineda nos pregunta, sé que esto está enfocado en la maternidad y los riesgos que involucran, pero ¿existe algún plan para la planificación responsable?
So, una de las estrategias que mencioné está enfocándose en la reproducción, pero es reproducción individual, no es un plan público o algo, pero sí, en Henry Ford tenemos diferentes departamentos que se también enfocan en la reproducción especialmente. Y si Miguel puede decir un poquito más con que él está, cuando menciona responsable, ¿qué está pensando?
Sí, le doy la bienvenida al doctor Manuel Cortés, que es de nuestra clínica Los Cobos de la Universidad del Bosque. Bienvenido, doctor, a esta conversación donde se están animando también en el chat a hacer algunas preguntas.
Muchas gracias, Mayra. Doreen, excelente presentación, muy interesante por todo lo que se puede hacer. Es un ejemplo de cuántas cosas se pueden considerar para actuar sobre ellas. Yo tengo una preocupación en relación con esto y es ¿cuánto vale, cuánto cuesta hacer todo lo que están haciendo? Por ejemplo, forman enfermeras especializadas, doulas, forman community health workers, forman a muchas personas. Bueno, sabemos que la Fundación Ford está para esto, pero a estas personas les pagan, es un trabajo voluntario. ¿Cuánto duran estas personas vinculadas a este tipo de actividad? ¿Lo usan como una parte de su tiempo? ¿Es un voluntariado? ¿Cómo funciona en ese sentido?
Los community health workers específicamente son empleados. Reciben pago, sí. Pero en el pasado necesitábamos pagarles de subsidios, de subvenciones. Pero ahora, porque el Estado, el departamento entiende y porque tenemos la prueba en publicaciones, en investigación, que el impacto de usarlos. Ahora es posible, no sé cómo decirlo, pero en inglés, bill for their time. ¿Cómo se puede mandar la cuenta para una visita con el doctor? También el tiempo con estos empleados es la aseguranza paga por este tiempo también. Está cubierto en la aseguranza.
Sí, en el seguro, en el
En
seguro.
el seguro, en el seguro. Sí. Pero diferentes procesos, diferentes de las estrategias que compartí, algunos son proyectos fundados por subvenciones, por subsidios, y otros son parte de las posiciones que mencioné, del director de Maternal Health Equity. Estos son posiciones pagados por Henry Ford. Pero sí, es un reto porque necesitamos más, pero solamente podemos hacer lo que podemos hacer. Pero sí.
Les tengo una siguiente pregunta a los dos. Nos la hace Lucas López y dice, siendo uno de los principales pilares la reducción de la mortalidad neonatal, ¿sí es posible llegar a 12 por cada 1000 en Latinoamérica y el Caribe?
Por favor, repita la pregunta. Por favor.
Siendo uno de los grandes pilares de este ODS,
sí,
la reducción de la mortalidad neonatal, ¿crees que es posible llegar a 12 por cada 1000 en Latinoamérica y el Caribe?
Yo no puedo responder a ¿qué creo yo? Es que tenemos que intentar todo lo que podemos hacer. Y aprender de diferentes posibilidades, diferentes opciones y adaptarlos para nuestro contexto y intentar investigar qué funciona. No sé, ¿vamos a lograr los ODS? La situación es muy duro, la pandemia nos retrasó en nuestro progreso. Sí, porque sí, en los Estados Unidos, por lo menos en Detroit, sí teníamos un progreso, pero como dije, no sé el impacto de COVID porque muchos de los programas están on hold, no funcionaban durante la pandemia y más o menos un año podemos evaluar, podemos investigar qué es nuestro nuevo trayecto.
Sí. Yo pienso que es una pregunta compleja en América Latina, porque la región es una región muy diversa. No es lo mismo hablar de Chile, por ejemplo, que hablar de Chile como una comunidad relativamente bien organizada, tradicionalmente con un muy buen sistema de salud, etcétera, que ha tenido sus altibajos en los últimos años, pero en general, como a la cabeza de los logros en salud en América Latina. Con una población relativamente pequeña, es allí un poco más fácil, diría uno. Es distinto lograrlo en Brasil, con la cantidad de personas que tiene, o en México. Y para el caso colombiano, nosotros tenemos y esto lo vamos a ver un poco en la sesión del próximo jueves, nosotros tenemos otros inconvenientes y es que en nuestro país internamente tampoco es uniforme. Entonces
Exactamente.
nosotros tenemos unas metas o unas tasas logradas en las grandes ciudades, pero tenemos muchas diferencias con ciudades intermedias y con los territorios periféricos.
Ujú, ujú, ujú.
Entonces, y las diferencias son muy grandes,
Sí.
son muy grandes. Entonces, cuando se saca una estadística para el país, esta estadística es un promedio de todo lo que pasa en el país y no refleja bien ni al que le va bien, ni a los que están muy mal, que se ven, no creo que eso lo vamos a ver en el jueves, la cifra que marcan las estadísticas que enviamos a las organizaciones internacionales reflejan un promedio, por supuesto, es alguna manera que hay que hacerlo, pero en la realidad, ciudades como Bogotá tienden a tener muy buenos indicadores, tienden a tenerlos, mientras que en regiones periféricas hay zonas del país con indicadores muy malos.
Ujú.
Entonces, las intervenciones para mejorar también tienen que ser diferentes y ajustadas a las
Es
realidades
correcto.
locales. Entonces, no puede haber una fórmula mágica que encaje para todos y allí está la dificultad de la situación para lograr mejorar.
Ujú. Y
Claro que sí.
esto, exactamente, esto es también el problema en los Estados Unidos, como un país muy rico y muy desarrollado, pero ¿por qué tenemos las diferencias entre diferentes grupos, desafortunadamente raciales, en Estados Unidos? El promedio, el número no significa mucho, pero es lo que tenemos
Sí.
para usar.
Bueno, hay más preguntas para Doreen. Miller Ovalle nos pregunta, ¿cómo ha sido la ruta de crear programas como los que se han creado en Detroit?
Bien, pregunta. Sí, a veces, algunos de los programas, de las estrategias serían ideas de personas, um, no, necesito decir que el, um, el concepto de community health workers es un concepto muy viejo de creo que los décadas de 70 o de Asia, de China y Bangladesh y empezaron ahí y solamente en los 20 años, hace 20 años que usamos más en los Estados Unidos y en los años muy recientes en estos proyectos en Detroit, entonces no son ideas que nosotros inventimos, ¿inventamos?
Inventamos.
Pero algunos nosotros vamos a conferencias, hay muchos, como dije, muchas conversaciones entre la comunidad, las diferentes organizaciones, el departamento de salud en nivel departamental, y estas ideas se desarrollan, pero sí. Y algunos son programas que nosotros, como dije, hacemos un grant, pedimos por un subsidio de una fundación, farmacéutica o algo, o el Estado.
Muy interesante lo que nos contaste de los health workers, que es como lo que decías al principio de tu presentación, el reciprocal innovation, esa innovación recíproca, de aprendamos entre todos para hacer las mejoras locales.
Sí, exactamente.
Bueno, la siguiente pregunta es de Lucas López. Definir políticas estatales para reducir mortalidad prematura mediante prevención y tratamiento, reconociendo la salud preventiva, ¿es posible? Voy a tal vez repetirla para que podamos desglosarla. Al revés, ¿es posible definir políticas estatales para reducir la mortalidad prematura mediante prevención y tratamiento?
Creo que sí, porque no sé si necesitan ser políticas estatales. Que nosotros los tenemos algunos en Michigan, en el departamento, pero creo en Estados Unidos es más que los sistemas de salud individualmente hacen las cosas que, pero el ejemplo de la Medicaid expandido de es una política estatal del departamento. Entonces sí, hay opciones.
Claro.
Yo pienso que sí, definitivamente sí. Lo que pasa es que a veces son difíciles de aplicar o difíciles de auditar, de monitorear. Pero en Colombia hay muchas políticas, muchas guías que se deben seguir, protocolos de manejo, etcétera, que dentro de nuestro sistema de aseguramiento, las aseguradoras le exigen a las IPS apegarse a lo que dice la guía del manejo. Y estas guías son utilizadas como la base para hacerle seguimiento a los casos que no tienen resultados satisfactorios y obligan entonces de esa manera a las instituciones que prestan los servicios a adherirse a estos esquemas y a estos protocolos de manejo, en el caso que nos toca, desde el control prenatal, el número de controles que deben hacerse, etc., hasta el momento de la atención del parto y el seguimiento posparto, etc.
Sí.
¿Qué es lo que pasa? Aunque estas guías son universales en el país y estas políticas son universales, no todas las instituciones están en la misma capacidad de cumplirlas. Y por eso son más exigentes, por ejemplo, con las instituciones privadas, que en el país prestan más o menos el 70% de la atención médica, pero es más difícil con las instituciones públicas, que tienen menos recursos y que el Estado tiene más dificultades en obligarlas a seguir estos procedimientos. Pero en la práctica diaria se ve cómo cada vez más a nivel institucional hay más adherencia a este tipo de políticas, de tener unas guías en las instituciones, de tener unos procedimientos que se deben seguir, etcétera, y eso mejora los resultados en salud en esas instituciones. ¿Cómo hacer para que eso se pueda generalizar más? Pues esa es la labor del Estado y de los sistemas de vigilancia que existen.
Sí. Y en los Estados Unidos, creo que la monitoría es bastante bien porque el problema de la litigación.
Sí, de la parte legal.
La parte legal, sí.
Las demandas.
Las demandas, sí. pero sí, nosotros tenemos entre los diferentes hospitales de un sistema, tenemos diferencias en los recursos. Es como, es simple, es muy complejo,
Sí,
pero sí.
sí.
Bueno, tenemos un comentario de Jenny Esperanza Ortiz Callejas que nos dice, como en otros países, se debe brindar un ciclo de formación a la madre antes de salir del hospital, pero lamentablemente salen a veces hasta el mismo día y no hay ese espacio de educación. Entonces, pues tiene que ver un poco con esto que ustedes logran, especialmente con el comentario de las madres que decían, lo mejor que tuve fue ese acompañamiento y esa asesoría. ¿Ustedes han implementado este programa en alguna otra parte del mundo?
No, creo que en nuestro caso, los community health workers pueden hacer mucho de esta educación, de la educación necesaria, todo el soporte que necesitan. Pero depende si puede usar una posesión como esto, porque sí, es muy difícil.
Yo trabajo en una institución y personalmente estoy a cargo del área de educación que tiene en uno de sus focos la educación a los pacientes. Y este punto que menciona Jenny es muy importante porque constituye uno de los indicadores que nosotros medimos para garantizar que todas las madres que han tenido los bebés en la clínica, al salir hayan recibido esta información de la que ella habla. Asimismo, una serie de cartillas y acompañamientos para que esté lo mejor informada y ojalá educada, aunque el tiempo es muy breve cuando son partos normales. El tiempo de estadía hospitalaria es de un día, más o menos, unas horitas más, unas horas menos. Tratamos de hacer todo lo posible porque salga bien informada, salga capacitada, sobre todo cuando son madres primerizas, en todo lo que tiene que ver con la lactancia, el cuidado del recién nacido, el cuidado de sí misma y su recuperación durante los primeros 40 días, etcétera. Eso lo hacemos y hay indicadores que miden si de todas las maternas recibieron esa información, si hay reingresos de maternas asociados a que no recibieron la información adecuadamente o no la comprendieron bien. Eso. Aún tenemos espacio por mejorar en ese sentido. No todas las personas que deberían hacer esa educación están tan bien capacitadas para hacerlo y al final de cuentas lo que uno chequea es un registro en una historia clínica de si hizo la actividad o no hizo la actividad y todavía tenemos espacio para mejorar al preguntarles a las pacientes cuál fue su experiencia y cómo eso que les dio o si no les sirvió para nada. Entonces, yo creo que estamos ahí en el punto que menciona Jenny, tratando de hacer el asunto. Estamos convencidos de que eso sirve mucho para que los resultados sean mejores, pero tenemos que trabajar mucho en nuestra propia capacitación de todo el equipo de salud para que tenga el impacto que se espera en las pacientes. Ahora, nosotros somos una clínica general en donde la atención de las maternas es solamente una parte de la atención y el volumen que tenemos no es el volumen agobiante de los hospitales del Estado, donde la cantidad de partos que se ven diariamente, etcétera, y la cantidad de recursos con los que se cuentan no son los mismos. Entonces, aquí, esto debe ser una situación muy diferente a pesar de que se quiera actuar de la misma manera y se reconozca la importancia del tema.
Sí. Y también en esta parte, de nuevo, quiero destacar la importancia de los community health workers, porque muchas veces la educación que nosotros hacemos es el nivel los pacientes, considerando su experiencia de cambiar de vida con el bebé, pero también las materiales ser muy complicadas y no se entienden, o hay problemas con el idioma, no, inglés tal vez no es su primer idioma, y estos casos también. Y también tenemos un departamento que se enfoque en la educación al paciente, pero no sé, esto es lo que tengo que averiguar, si han revisado la información que nos damos a las mujeres, a las familias, y para averiguar si que se pueden comprender la información.
Creo que tal vez en eso se está innovando con toda la salud digital que viene a partir de COVID, y no sé si nos puedas también hablar un poquito de esa experiencia que tuvieron a partir de eso.
Sí.
Bueno, tenemos una siguiente pregunta, que es Jesús David Pérez. ¿Cuál ha sido el obstáculo a la hora de realizar estrategias que permitan la mejoría de los servicios de salud?
Well, un obstáculo muy grande fue la posición de los community health workers. Como dije, por muchos años no podían cobrar el seguro, no podían incluir en el seguro. Y esto fue un gran obstáculo, porque no podían usarlos tanto como podemos usarlo ahora. Sí. Pero también, como dije, porque algunos de las estrategias son fundados por recursos de fundaciones o algo. El programa, cuando los fondos acaba el programa, ¿no? Sí, y también las otras cosas que, porque la mayoría en la ciudad de Detroit, el estatus socioeconómico es muy grave, y las madres necesitan tanta support, tantas otras cosas para su vida, para darles para cuidar los niños en lo mejor manera, la mejor manera posible, porque hay tantos otros problemas, y abordar estos y mitigar estos es un obstáculo. Entonces, por eso el proceso de conectarlos con los recursos que están en la ciudad o en otras organizaciones es muy importante, es sumamente importante.
Claro que sí, se nos han acabado las preguntas. No sé si el doctor Manuel quiera hacer un comentario adicional, o Doreen.
Sí, yo actualmente tenía unas dos preguntas para los participantes, o para...
Muy bien.
Si alguien quiere compartir una estrategia que ellos han usado,
utilizando.
Algunos necesito más ideas para... Yo también necesito aprender. Sí,
sí, tal vez si alguien tiene y quiere participar, no sé si existe la posibilidad de que le puedan abrir el micrófono y participar con una pregunta en vivo, o no, tiene que ser por el chat.
Por el chat, pero yo propongo que a los que quieran, como tú nos mostraste su contacto, entonces nosotros podemos, las personas que tengan ideas, mejor dicho, para Doreen, pueden escribir a cátedra.ods@unbosque.edu.co y le pasaremos las ideas a Doreen para que podamos construir algo muy interesante para lograr este objetivo.
Sí, y si alguien tiene más preguntas o quiere hablar de algo de una de las estrategias en más detalles, le puede conectarlos con las personas que están en cargo de estas programas.
Tenemos una nueva pregunta. Janet Peña nos pregunta, ¿conoces la estrategia IAMI, Instituciones Amigas de la Mujer y la Infancia con enfoque integral?
Yo no, pero IAMI. Yo voy a buscarlo en internet. IAMI, Instituciones Amigas.
Nos sirve a todos para que sigamos aprendiendo un poco más.
Lo buscamos. Lo que sí se puede decir es que en Colombia, para traer el tema a nuestro país, hay muchas iniciativas para trabajar acerca de la morbimortalidad y reducirla relacionada con el binomio madre-hijo. Desde políticas oficiales y recomendaciones y programas especiales que se deben seguir, hasta programas probablemente como esta iniciativa de mujeres de amigas de la mujer, etcétera, que pretenden colaborar en este proceso de mejoramiento. Creo que a nivel institucional, gubernamental, se han hecho esfuerzos en reconocer el impacto cultural que hay en lo que tiene que ver, por ejemplo, con la salud materna entre poblaciones indígenas, por ejemplo, grupos étnicos como afrodescendientes.
Con ancestrales, con los...
Exactamente.
Sí.
En donde se trata como de hacer un empalme entre la cultura que tienen estas comunidades con las posibilidades que puede ofrecer el sistema de salud. Y gran parte de lo que se ve hoy en día en Colombia es que en temas como la mortalidad materna, el acceso a los servicios de salud para estas poblaciones que habitan zonas rurales o periféricas muy alejadas, es uno de los aspectos más importantes en los casos de la mortalidad materna, y gran porcentaje están relacionadas con la habitación o el lugar de residencia geográfico distante, y segundo, con pertenecer a estos grupos un poco más vulnerables, porque son precisamente las personas que tienen más dificultad en acceder a los servicios. Entonces, hay espacio para todos, yo creo, y hay espacio para muchas iniciativas de las personas. Hace falta tal vez más compromiso político en el buen sentido, ¿no? El political will para seguir trabajando con entereza en esto, y, como siempre, recursos. Entre más recursos tengamos, ojalá más facilidades de propender por un servicio adecuado para la salud de estas maternas. Yo quiero aprovechar para felicitar a Doreen y para agradecerle su presencia en esta cátedra y dejarle siempre la puerta abierta para que cuando quiera participar y contarnos esas experiencias que tienen allá, que deben contribuir a inspirarnos a nosotros en lograr nuevas iniciativas y en aspirar a mejores resultados en todos estos aspectos relacionados con los ODS en Colombia específicamente. Así que
Sí.
Quiero
Sí.
contarles que en el chat porque Doreen lanzó, digamos, esa apuesta a nuestros estudiantes y uno de ellos nos tiene una idea que es Nicolás Fernando Roballo. En el reto In a World 2020 hicimos con nuestro equipo de trabajo una app para detectar enfermedades, sobre todo respiratorias. Entonces, los estudiantes también están muy interesados en preguntar de qué se trata la app. Así que estaremos enviando esta información más adelante para Doreen. Y de verdad también yo me uno a las palabras del doctor. Muchas gracias por acompañarnos el día de hoy. Creo que fue una charla inspiradora, nos hizo pensar en otras formas de trabajar este ODS.
Muchísimas gracias por invitarme. Para mí siempre un honor, un placer estar con ustedes. Y sigo aprendiendo de la situación de la infraestructura de salud en Colombia y mucho más opciones, mucho más oportunidades para colaborar con ustedes y sí, como dije, si algunos de los estudiantes tienen preguntas, me pueden darme un correo y estoy listo quedo pendiente para la próxima vez.
Claro que sí. Todos nuestros estudiantes que tengan preguntas, saben, pueden escribirnos al correo de siempre, catedraods@unbosque.edu.co. Muchísimas gracias nuevamente, Doreen, por tu presentación, y al doctor Manuel Cortés lo esperamos el próximo jueves, es quien será nuestro conferencista y nuestro profesor de la sesión complementaria de este ODS de Bienestar y Salud. Nos vemos entonces el jueves 24 de agosto y feliz noche para todos.
Feliz noche.
Hasta luego.
Gracias a todos.